RetinaRounds, episode number 132, Traumatic Giant Retinal Tear Detachment. Giant retinal tear detachments are a subset of rhegmatogenous retinal detachments that require special consideration. In today's case, presented by returning guest surgeon Dr. Saarang Hansraj, we will discuss some of the basic considerations when performing GRT detachment repair, including whether or not to remove the lens, the role of a scleral buckle, how to avoid retinal slippage, and choice of tamponade agent. Dr. Hansraj's patient is a 19-year-old male 1-month status post-corneal laceration repair who presents with a macula-sparing giant retinal tear detachment. Let's see how he manages this case. All right, you can see that this patient has already had a corneal laceration repair, and fortunate for the patient, the patient's lens is quite clear, and so Dr. Hansraj is going to perform a lens-sparing vitrectomy for this patient with the GRT. You can see here that the core vitrectomy is being performed, and there is a little bit of haze to the vitreous. This is most likely some dehemoglobinized vitreous hemorrhage. Dr. Hansraj is also using some triamcinolone to stain for any residual vitreous, and you can see some of that inferior vitreous hemorrhage there. Now, using the soft tip, some hyaloid attachments at the temporal macula are elevated. And now Dr. Hansraj is going to go on to perform the peripheral shave. And you can see here that an assistant is performing scleral depression while Dr. Hansraj is performing the vitreous-based shave, which is very important in these eyes since they are at higher risk for developing PVR and potentially a redetachment. Now, once the peripheral shave has been performed, Dr. Hansraj is now going to actually place an additional trocar at the 6 o'clock clock hour position, and he's going to place a chandelier light. And the reason that he's doing this is so that he can be more thorough with the peripheral shave right at where the GRT is located. You can see here that with self-depression, he's removing that retinal flap and trimming the retina and the vitreous back to the ora serrata. He wants to do this himself because he wants to be as thorough as possible without potentially damaging the crystalline lens. So that's certainly an option, or you can, if you have a skilled assistant, you can rely on an assistant to depress for you. Now, endo laser is being performed around the edge of the GRT and in some additional areas here in the nasal periphery. Now this looks like it's being done with perfluorocarbon liquid in the eye, and now rather than removing the PFCL and going to air, Dr. Hansraj is going to perform a direct PFO silicone oil exchange, and this is to decrease the risk of retinal slippage. You can see that soft tip removing the residual PFO. Now this is the patient's postoperative outcome at week 3, and you can see that the patient's best corrected visual acuity at this stage is roughly at the level of 20/80 with silicone oil in the eye. The lens is still clear, the intraocular pressure is normal, and you can see on the OCT that the macula looks to be so far unaffected, and this is really a very nice anatomic outcome. Dr. Hansraj is planning on removing the silicone oil in about a month's time. So here are some considerations when repairing a giant retinal tear detachment. Now, for all of these clinical questions, I will provide my approach, but to the RetinaRounds community, please share with us your approach and rationale, since there are many ways to tackle the same problem. Now, one question that comes up is whether or not to remove the lens. Now, GRT patients are at a higher risk for PVR, and a thorough vitrectomy with vitreous-based shaving is mandatory. However, the presence of a crystalline lens or even an IOL can limit the degree of anterior base shaving that can be safely performed, and so some surgeons advocate for lens removal. And the counter-argument is that removal of the lens adds more surgical complexity and may not always be necessary. My approach is to remove the lens if it's interfering with visualization during the surgery, and to consider lens removal in cases with significant preoperative PVR. And when removing the lens, some surgeons prefer to implant an IOL or to leave the capsule intact for a sulcus IOL at a later date. In my hands, if I remove the lens, I typically remove the capsule as well to remove any scaffold for anterior PVR, and I'll consider placing a secondary lens at a later date depending on the patient's vision potential. In this case presented by Dr. Hansraj, I also would have left the lens intact. Now, second question is whether or not to place a scleral buckle. An encircling band can support the vitreous base in the non-GRT areas and decrease the risk of a PVR-associated retinal redetachment. However, the placement of a scleral buckle can increase the risk of retinal slippage and postoperative retinal folds. Now my approach is to place a low-lying encircling band, typically a 41 band, and to tighten the band after the air fluid exchange or direct PFO silicone oil exchange has been performed to decrease the risk of retinal slippage. Now, while I use a scleral buckle in almost all GRT cases, I think it would have been particularly beneficial in this young patient given the history of trauma and vitreous hemorrhage that can further increase the risk of PVR. Next, how do you avoid retinal slippage? If performing a PFO air exchange before implanting silicone oil, it's critical to meticulously remove any fluid near the edge of the GRT before taking down the PFCL. And this will require many minutes of drying and waiting and redrying and waiting and redrying some more before the PFCL is taken down to ensure that as much fluid has been removed as possible. Another option is the technique shown by Dr. Hansraj to perform a direct PFCL silicone oil exchange. Basically, the entire eye is filled with perfluorocarbon liquid, and then while silicone oil is injected, the PFCL is removed, either passively with a fluted soft tip or using the dual mode on some vitrectomy platforms that allows for active oil injection and active extrusion. In Dr. Hansraj's case, the oil injection syringe was held by a skilled assistant, and alternatively, he could have held the silicone oil syringe himself and used the chandelier light for illumination. Now last, should you use gas or oil as a tamponade agent? Now in this case, oil was used, but another option, especially given the superior break, would have been to use a long-acting gas tamponade like C3F8. Now my general approach is to use C3F8 gas, but I will use oil in patients who need to travel or who live at high altitude, patients who are unable to optimally perform the necessary head positioning, or those who are monocular and don't have the social support to manage with gas in their better seeing eye. Again, to the RetinaRounds community, please let us know your thoughts so that we can all learn from each other. And to Dr. Hansraj, thank you again for sharing this very educational case. If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.